computer. All right, well, Softwave U got a special guest with us today, and it's Dan McCarthy. Dan he brings close to 20 years in healthcare. He's been in Atlanta the last 17 years, trained at Emory, which is awesome. He's been working with Softwave over the last year, and a big shout out to Dr. Rob Windsor, who's an amazing interventional pain doctor. And kudos to him because he found this technology years ago and has been just a great innovator in this field. And Dan, you work with Dr. Rob Windsor and you do some stuff on your own. So we'll be chatting about that in just a minute. So, hey, this is one of the most, I guess, signed up for our Tuesday night call as we've seen in quite some time. So really excited. These are things that are, these type of cases and vascular issues are walking into our office now like every week. And instead of saying, oh, I don't know what to do, or I'm going to do 1300 energy level, we're bringing on Dan, who's got a great background. Dan, tell us a little bit about yourself and literally how you were in this, got into this field.
Well, I was a medic in the Navy for 9 years and did a variety of roles in that realm. Towards the end, I knew I wanted to get an advanced medical education, and so I didn't know if being a medical doctor or really what my trajectory was going to be. But I was talked out of going to medical school by some doctor friends of mine, and they steered me towards the path of being a physician assistant. And I found it to be a pretty gratifying career. I trained initially in doing primary care, did some orthopedics, interventional radiology, wound up taking a job on a whim for a vascular clinic that specialized in lower extremity arterial disease, trying to avoid amputations. So doing endovascular angioplasty, restoring blood flow to insufficient flowing limbs, and then also learning about vein disease, which transitioned into working at Vein Atlanta, learning about the vein and lymphatic system. And what I found in those vascular roles many times were patients that were suffering from conditions that I commonly saw when I was working in primary care. I was, very familiar with chiropractic. I have worked in several clinics with DC, MD friendly institutions. And so there's a lot of those cases that I saw that we tried to treat, from orthopedic and chiropractic standpoint, we missed a lot of the vascular stuff. And so when I became a vascular specialist, I realized how easy it was to identify some really simple problems for patients and some symptoms, and then begin to treat them. But I also saw that these patients were coming to see the vascular specialist as like the last ditch effort. They tried everything else and then they wound up in our arms. And so I sort of took it as I took a torch to say, well, we need to educate the masses. And so when I became a Softwave user and then became a part of Softwave University, I saw an opportunity to help to educate, my fellow users about, hey, what are some really simple, easy, obvious things that you can see with your patients that you can discuss with them that will help you to avoid potential complications or patient complaints when I think one of the comments was a patient had unfortunately developed some varicosities, and knowing what I know about superficial vein disease, it's varicose veins don't just pop up. They've been there for some time, and so conditions were just right for those vessels to become apparent to the patient.
Let's also kind of remind folks and doctors on this call that they have comorbidities. They have 31% of the people that are walking into our clinics are diabetic, type 1, type 2, mostly type 2. They're on a couple different medications. So they have blood flow issues. That's one of the main things. And so tell me, what I really want to know is like, what happens at these vein clinics? And, they used to be all over, commercials all over the place. And obviously insurance was paying for something, but what happened?
Yeah, they got a bad rap, but I mean, a lot of what we treat were achy, heavy, tired, crampy legs, patients that had, really severe knee pain. And, they did all kinds of, Synvisc, joint injections and, this and chiropractic treatments and expensive knee braces, and nothing really did the trick. But nobody ever tried, compression socks in a patient, and so it was like this super simple, hey, wear some compression socks. But the reason that they were never told that they didn't wear compression socks maybe is because they were just told to go buy compression socks, and they went to the pharmacy and they bought, a pair of really crappy compression socks, and they had a hard time getting them on. They're like, well, I'm just not going to wear these. And so nobody ever sat down and explained, hey, this is why they work, and here are some good options, and here's what you can get. And, there's some really simple things that we can do as clinicians that can really empower our patients to make good choices for themselves.
Yeah. And have, them follow through with the recommendations.
Correct.
So, yeah, I guess I want to know, so what do the vein clinics do? And I know you've got a nice little presentation if that's on. Then
so they do. So
the treatment?
Mostly they do ablations of the superficial venous system, the great saphenous, the small saphenous. They'll do energy-based ablations on the deeper aspects of that. And then
is that going through and really kind of taking out the valve system, because it's kind of like a lock?
Yeah, the valve system's already pretty much already pretty much gone, and so it just basically cauterizes the inside lining of the vein, and it seals the vein shut, either with radio frequency energy or with laser energy. And then in other areas they have to use like a chemical sclerosant, in which they'll use like an ultrasound to guide the imaging to make sure that they don't inject in a deep system at all.
So in a venous system that works properly, they always say like your lower limbs, and venous system is like the lower heart, right? The way it uses the system. So when that's blown out,
the deep system is because the deep system is supported by the musculature of the leg. The superficial system it's just this loosely bound in just tissue and fat, and there's not really the body doesn't have a great way to support it. So the superficial system winds up being really a reservoir system. And if that reservoir system becomes, damaged or impacted, it's going to create, back pressure.
And that's where we get the lymphedema and edema and stuff like that.
Well, the edema is, yeah. And so when we get to the slide bank, we're going to talk about some common things that you'll see. And so, curveballs and things that don't respond like you think they were going to respond. You're like, well, I don't understand why this is not going the way it should go. And so I can help people understand like why and what it takes to fix those problems.
Okay, good. All right. I'm going to share this with you, and oh, no, not that one. Sorry. I'm going to ask, let's see. I'm going to ask Dan to be our host for a little bit, make host, and then go ahead, sir, take it away. I'm excited because we're learning some great stuff tonight, and I think really what it's about, it's improving patient outcomes, and this is probably one of the weakest things that we're getting.
Looking right at my slide bank right now, so I don't know, is everybody able to see the slide bank all right?
No.
All right, let's see here.
Click on the one that should be highlighted. And you're going to have to click share screen.
All right, hold on here. I'm a little bit new to the whole, oh, good gracious.
Nope, we can't see. That's right, Bruce.
All right.
We'll tell you when.
Share screen. All
yeah.
Right.
Click that. And then you should have like 5 things that pop up. And you want to click the one, you want to double click on the one that you want to share.
All right.
There you go. Boom. Shakalaka.
All right. So here's the slide bank. It's just, basically, helping to improve our patient outcomes and expectations with the vascular mindset. I'm not trying to make anybody a vascular specialist by any stretch of the means, but there are some very simple things that you can see when you see your patients from a symptom standpoint or from a surface anatomy standpoint that are really going to make you seem like an all-star. So we're going to talk about, the basics of, veins, the basics of arteries. We're going to take a look at some edemas. We'll take a look at some surface findings, try to understand like what kind of testing that you can do, or what's the trajectory that the patient is going to wind up taking. What are some in-office things that you might, if you want to get into it, you can. I'm not going to say that it's absolutely necessary, but some people really like to do these things, and so we can talk about some tests that you might be able to do in your office, and then ultimately how to manage these patients in the long run. So vein basics, chronic venous insufficiency, also called venous reflux. Normal healthy veins, about every inch or so from the foot up to the heart, are one-way check valves. Over time, those valves can wear out. Unhealthy valves ultimately leads to backward flow, which leads to pooling. That pooling leads to pressure, and that pressure can lead to a variety of symptoms. And I have a diagram here of various stages of vein disease as we classify vein disease: CEAP, 1, 2, 3, 4A, 4B, 5, and 6. Spider veins, varicose veins are 3, edema. Telangiectasia 1, varicose vein 2, edema 3. Inflammatory skin changes are 4A and 4B, and then ulcerations are class 5 and 6. So I just want people to know, and anytime we talk about prevalences or estimating, it's a gross estimation. We're usually behind the curve on estimating how many people are affected, but about 40% of people in the U.S. are estimated to have chronic venous insufficiency. What are some of the risk factors? Family history. If you've got one parent that has a history of vein disease, you've got a 50% chance. Both parents, potentially greater than 80% chance of having venous reflux yourself. Female gender, unfortunately, progesterone has a nasty effect on the peripheral venous system. Pregnancy, we're talking about volume overload. So sorry, ladies, you really bear the brunt of this, but we can help fix it. Prolonged sitting, standing, truckers, medical professionals, we're on our feet all day. I'm sure many of you notice your legs maybe feel achy, heavy, tired. As we get older, the valves wear out. Obesity certainly is a risk. And then a lot of times, since we're in the healthcare field, a lot of drugs are almost always going to be a culprit. So, always take a good look at what the patient's taking, because that can clue you in as far as what some of their problems might certainly be. If they're taking blood pressure medicines, they're already at risk for having, peripheral arterial problems as well.
Hey, Dan, also just keep an eye out. You might have to be letting attendees in, okay? Just keep an eye out because you're the host.
All right, got it. Admit. All right, there we go. So vein-related symptoms: achy, heavy, tired, swelling in the ankles and feet, bulging varicose veins, spider veins, itching, irritation, dryness, tingling, a burning sensation, ulcers, non-healing wounds of legs, skin discoloration, redness, or inflammation. Those are always big ones. Some of these diagrams here, you can see some various stages of vein disease. A really good place to look on everybody's legs is at their medial malleolus. If there's any kind of bruising or spider veins or any kind of discoloration there, like peripheral to that, it's a train wreck, and they should really get it checked out. So that's a really super simple one to look at. That'll clue you in to look for other problems or ask these types of probing questions. And the worse it looks, the worse it is.
Let me ask you, go back to that one. That's really a good one. The one in the upper right corner, that's the purple malleolus. And so I will tell you, we did like experimental stuff. We did not see change in that.
Yeah, that's tough. That's like fiber. That's hemosiderin deposition, and that iron. I mean, that's skin rust. You know what I mean? Okay. And that's permanent. It's
irreversible
sclerosis. It's elephant-like. It's just, you're not going to fix that.
It's like a well done steak that you want to send back and said, I want it less done, and that's just not.
Sorry.
All right. Okay. Good. Good stuff. Keep going.
Yeah, that area is super high risk for the development of ulcers, and so managing the any kind of distal pressure or any pressure, backflow vessel around that, you got to get those people treated because they're super high risk for ulcerations. All right. PAD, obviously, narrowing of the arteries, reducing blood flow, ischemia, tissue damage, necrosis, and ultimately amputation. So I've been to several amputation symposiums, and the numbers aren't good. Amputations are horrible. They're so there's such a high percentage years ago of people weren't even having basic angiography and attempts to open these vessels, and amputations are just it's just like we got to stop that stuff. So
I got a couple of patients who were diabetics, had weird fractures, kind of getting out of their truck, boom, ankle fracture, poor circulation, diabetic, turns to osteomyelitis. Yeah. And guess what?
It's
below the knee amputation. Like there were people they never thought, or I never thought would get amputations, but that's what happens. The cool thing is, looking at the last 11 years in Austria, They've saved over 70 million euros working with non-healing fractures, preventing them from going that way. Good stuff. Keep going.
Yeah. So, looking at risk factors, the main issues, smoking, diabetes, hypertension, cholesterol, kidney disease, history of coronary artery disease. I mean, the odds ratios, it's not good. So, people, you have to get your people, if they're in rough shape, you got to be like, look, lifestyle changes. You got to like make some serious choices for yourself. Like, get busy living or get busy dying. Things that you can modify, smoking, like we said, type 2 diabetes, hypertension, poor nutrition and diet. That's a huge one nowadays. And so, try to be mindful of helping your patients focus on functional nutrition. That's a big one. Symptoms of PAD, the easy identifiable stuff, or this claudication cycle: rest, walk, pain, rest, walk, pain, rest, walk, pain. I mean, like ask patient, how far can you walk? Can you walk out to the mailbox and back without getting, without your legs hurting? A lot of times it'll feel like cramping in the legs. The legs feel weak or numb. They're, obviously cold. Hair loss or shiny shins. This is a really big one. I want to reel this back to a vein condition, because hair loss on the lower legs is a big one, and we've probably all heard this one from patients, especially when they're young. Oh, I wear combat boots, or oh, my socks rub my hair off my shins. I used to believe that stuff before I got into vascular, and I don't believe that stuff anymore. It's certainly,
you're absolutely right. It's funny. It's
definitely a sign.
Really, it's part of the autonomic neuropathy process. So first you lose the blood supply to that area, you lose sweat reflex, and then you have the hair loss as well. So
yeah, I look back on myself, when I was 19, I was in the Navy. I was, doing, medic training in North Carolina. I lost all the hair on my lower legs. I was like, oh, I just had pattern balding on my legs. Ha, 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 ha. And, now I've got varicose veins. I'm like, oh, great crap. Now I got to get them fixed. And, I tracing it back, and I'm like, if I had only known and worn compression socks back then, it would have, it would have made a huge difference. But vis-a-vis, back to this, when PAD is worse is when you have pain at rest, particularly at night. So a lot of times with these leg pain symptoms, you ask the patient, like, what is the timing of your, like, when are your symptoms worse? And if it's a lot of times, if it's at the end of the day or at night, sometimes these restless leg symptom pains are the result of venous discomfort that's gone on over the course of the day. The patient's now recumbent and flat, and now that pressure is relieved. And so now the legs are throbbing and throbbing and throbbing because, that pressure has finally been relieved. So be mindful of those symptoms there. All right. This guy's not having a very good day. Likely there's something going on, from a central standpoint, like cardiac or whatever. But I mean, edemas, they suck. So
kidney function too, guys. It's a number, like we see a lot of patients who are on dialysis or even doing dialysis at home, and they've got kidney failure. So there's something shutting down.
So
these are not healthy, and they've all walked into our clinic. So
yeah, got to be mindful of that. So I wanted to put, I put these slides up here because these were some curveballs that I saw when I was working in veins, that you might not be able to help them out. You got to kind of be smart about how it is. The first one is lipedema, and lipedema is always a dead giveaway, because you're going to see this characteristic cuff at the ankle. It's like anything below that cuff, like the foot is completely normal, but it's like they have like this they're wearing like a fat sock almost. That, unfortunately, it requires surgical correction. And I think I'm so happy I live in Atlanta, where there's one of the, where there's like a leading world lipedema surgeon in Roswell, Georgia. And that's one that really disappoints.
Go ahead, give him a shout out. What's his name?
Yeah, it's been so long since I have had to refer a patient. I don't remember the name.
That's okay. You'll think of it.
I'll look it up. Anyway, so lipedema is a frustrating one, because even wearing compression socks doesn't do much to help that situation. The second one is lipodermatosclerosis. This is, leading back to what Dr. Matt was pointing out earlier. This is like a fibrotic band that wraps around the entirety of the calf. And it gives you this characteristic upside down champagne bottle appearance. That's super important to get that patient's veins fixed and make sure they don't have any vascular problems, because they are also significantly high risk for developing ulcers of the skin. The next one is lymphedema. This was can be a really confusing one, but the easiest way to identify if a patient has lymphedema or not is you ask them in the morning, before you put your foot back down onto the floor, is your foot still swollen? And if that's swollen, and that foot is still swollen in the morning time after it's been up all night, that's lymphedema until proven otherwise. And that's going to require either compression socks or some lymphedema therapy to get that better. So
not a surgical intervention.
Problem, maybe not, but they got to get that lymph problem fixed first.
Not
and then
a
the last one is the typical
not a
edema,
surgical
which you're going to see, you know, in either a venous problem, hepatic, cardiac, or what have you. So talking about the surface signs again, there we go. We have the the shiny hairless shins, and then around the ankle, that's a finding called corona phlegmatica. So when you see something like that, we were actually allowed to classify that as, we actually consider that to be a varicose vein. So that would certainly worsen the patient's venous prognosis. Malleolar bruising, that's with the atrophy blanche. When you see atrophy blanche, that's a bad sign. That's evidence of skin breakdown. So maybe there's been an ulcer there before, and it's more prone to redeveloping. So be really careful around lesions like that. All right, so what do you do? What's the easiest way? What's the best thing that you can do for a patient? Well, a bilateral lower extremity vein ultrasound is really going to be the gold standard for mapping out what vessels in that patient's leg are going to need to be treated. No matter what you do from a vein standpoint, compression socks are going to be your friend. It takes the patient a little bit of getting used to wearing the compression socks, but once I got to tell you, once I started wearing compression socks at work, my legs felt so much better every day. I'm dragging my feet to get my veins fixed, but wearing those compression socks really makes a huge difference. And so, if you want to get your patients to wear compression socks, I would say start wearing them yourself, and they will benefit you. Trust me.
Do you recommend any?
Yeah, I'm going to get to that. There's a brand that's based here in Georgia called Sigbar. So I've tried a whole bunch of brands, and theirs far and away is the one that I recommend. What do they do to treat? Vein ablation, either endovenous laser or radiofrequency ablation. Varithena is a chemical sclerosant, which is still administered by ultrasound guidance. Sclerotherapy for some of the smaller vessel stuff. And then also phlebectomy is another way to treat varicose veins. There's been some questions on the panel on the Facebook group about whether or not Softwave will help treat vein disease. It's plausible, but if you're not sure, what's causing them to have that surface vessel show up in the first place, maybe get that patient referred and let that primary closure get done, and just ask that patient to get returned to you. Say, hey, look, you go get all this feeder stuff done, because if we treat this one vessel, it's going to come back somewhere else. Like, the body's super smart. Like, it knows how to make new blood vessels, and it will make new blood vessels, and that patient will get other other surface vein stuff popping up. So just be mindful of that. For arterial, you can certainly do ABIs in clinic. Looking at the foot, there is this is what we call an angiosome. So for the deep arterial system, there the tibial arteries branch into three: the anterior tibial, the posterior tibial, and the peroneal. And each of those vessels is going to supply blood flow to a particular area of the foot. So if you want to do like capillary refill or sort of check around the foot by blanching the tissue, and that can kind of give you a clue as to where a patient may have some blockages occurring. But you can always palpate the dorsalis pedis on the dorsum of the foot, or the posterior tibialis at the behind the medial malleolus. Let's go back here. Really if you suspect arterial for your patient, a referral for bilateral lower extremity arterial ultrasound really is the way to go. Let them map it out, and I always like, hey, it's an inexpensive test. Go get that patient cleared, and if everything's good to go, then nothing holding you. But at least you ruled that out for the patient. There are some medications like cilostazol that can be taken for arterial conditions, but I'm not really big on meds. Angiography is the gold standard, which can then lead to endovascular atherectomy or angioplasty. Trying to avoid things like surgical bypass or even worse, amputation. and then talking a little bit about lipedema or lymphedema, lipedema requiring a surgical consultation, and lymphedema being best managed by lymph therapy or possibly getting that patient a lymph pump.
Hey,
I just threw
question.
this random chart in here just because like I like the colors and I figured I should have a chart. So enjoy my random chart for a moment. Matt, you had a question?
Yeah, so the angioplasty, especially one of the companies out there is Shockwave Medical. You guys should keep an eye on them. They are pretty cool. They do like an angioplasty and they go down into arterial and they find where the blockages are, and they have a pump that blows up, and then inside they have our SparkWave technology, very similar to a lithotripsy. So I think they're like $5 billion right now. They've been on the market. They went public 3 years ago. And they just recently, in the last year and a half, got approved for the rest of the body. They used to be only lower extremity.
Well, I'm a believer. So like that'll be fantastic when that can be done. You know, I've seen some just absolutely amazing things done, endovascularly with a, wire and a catheter and, a little atherectomy bulb. And it's just like there really is nothing that you can say when a patient's on the angioplasty table and they're like, my leg feels better already, and their leg is getting warm and well perfused, and they're like, look, my pain is gone, and there's nothing more rewarding than that. And I've actually seen the same thing happen, doing vein cases as well. So be mindful of of the benefits that can be out there for the patient. So
that's awesome.
Talking about Sigvaris now, I definitely wanted to throw this in here because one of the things I love about all of my chiropractic brethren and sisters are you're very entrepreneurial, and if you're looking for something to have in your clinic to try to generate some revenue, this is one possible source. Sigvaris they're a great resource. They can certainly help you set up any type of retail space that you might want to do, or try to get you pricing. You're going to spend about 47 to 49 bucks a pair, which, and they talk about MSRP from 85 to 98 bucks. You just got to figure out what type of socks you want to sell, but you really want to look at it from a medical standpoint. If you're trying to get benefit, 20 to 30 millimeter mercury socks are the way to go. If you get your patient going in compression socks and that patient winds up going to see a vein specialist, that vein specialist is going to be drooling and fawning over whoever it was that prescribed that patient compressing socks, because they really help them from an insurance standpoint, like quiet down any type of pushback or necessity for the vein type treatment, because the patient maybe had tried and failed. So if you can get them going in compression socks, the vein folks are going to love you to death. And then for more severe cases, those patients are going to need 30 to 40 millimeters of mercury. But if you're thinking about getting somebody in there, that person should be seeing a vascular specialist and make sure that their vessels are all good to go. One of the things I found with compression socks is that Amazon is not my friend. And so I find it a little bit difficult to have the compression socks. I'm trying to figure out how to integrate it back into my business model right now, but it's something that I definitely think people need. And so if you can figure out a way to get them using the compression socks, like, have at it. Let's see here. All right, so using your vascular mind, like what are you going to do? So your patient presents for the evaluation, and don't forget what you're seeing when they show up to you, because the patient's not making the connection from their symptoms to what you might be thinking that their problem is. It's not necessary, to do a super robust evaluation for yourself. There's some simple things that you can see and just look at the legs. It might take you 1 or 2 visits to pick up on some of the subtle vein stuff, but just give it time. If you're looking at their legs long enough, they'll show you something. From a treatment planning standpoint, I would say, don't stop, your wheels of progress. Don't slow down your plan to use Softwave or integrate it into any of your things. There's not a whole lot I can say that Softwave is going to do to help treat refluxing saphenous vessels or significant varicose veins, and that's just gonna that needs to be fixed. But you can certainly help out with whatever it is that their primary thing that that they came in with. And I would certainly encourage you to maybe try to build some relationships with with a local vein clinic or a vascular center near you, or somebody that also treats, because I really think that referral should be reciprocal. I had plenty of patients that I would see that I would like, hey, I think you need to go see a chiropractor. I think what you have going on is not what you think it is, and and you're convinced that you want to get your veins fixed, and I'm trying to talk you out of it, but they won't listen to me. And I'm like, so I appreciate having, somebody to send a patient to if they're willing. Managing outcomes, if you know that if you have a heads up on their vein stuff, you can certainly, hold on, let me read this one here. I got caught off guard. Yeah, if you find if you find problems and you're able to help fix them, a patient is certainly going to appreciate that, and you can certainly get some big wins if you continue to treat what you think it is, but say, hey, look, patient, I love you to death. I think this might be going on with you. I would encourage you to go get it checked out. Whether you do anything or not, like let's just peace of mind, like just get yourself checked out and see where you're at. If you're interested in any kind of supplements, the ones that I remember from when I was in working in the vein clinic was diosmin. It reduced the oxidative stress. Patients say, well, can I just, can I eat, enough oranges? I said, well, yeah, sure. You have to eat the equivalent of 140 oranges, including the peel, and nobody's really willing to do that. So, one capsule of, I think the prescription version of diosmin was Vascular, or the over-the-counter strength is about 600 milligrams. So if you're looking for like a vascular supplement, something with diosmin of about 600 milligrams is going to be your best bet. From the arterial standpoint, nitric oxide support, that's always good. There's a couple different ones. There's like super beats. Some of the nitric oxide supports, their main ingredient is L-arginine, and when we're over age 40, we lack a particular one of the cofactors to make L-arginine effective. So using ones like Berkeley Life is nitric oxide, one that I use. So if you want to have a nitric oxide support in your clinic, very easy to do. And wholesales for 24, MSRP is about $50, and it works great. I've had an easy time selling it. You test patients with a test strip, you show them they're depleted, you show them how to take it. It's just basically vitamins and nutrients to help support native NO. And then from an arterial repair standpoint, there's a supplement called Arterocell, which is the only one that's been shown to help repair the endothelial glycocalyx. So areas where the arteries are damaged, this helps to repair sort of that repellent system, if you will. Summarize, with a small amount of vascular know-how, you can be pretty effective in helping integrate a vascular mindset into your patients and getting a better outcome. And if you're going to do anything for your patients from a vascular standpoint, from veins, you should definitely integrate compression socks no matter what you're doing. So if you're soft waving anything varicose or spider veins, like, you need to have them in compression socks. And my kids, thank you very much. Matt, how do I hand it back over to you?
You can just say stop sharing, or let's see.
All right, did you get it back?
There you go. I think so. All right, well, great. Yes, I got it back. Hey, round of applause, everybody. Clap. You guys can put emojis on there, do whatever you want in the chat. That was great, Dan. Really informative. Yeah. And again,
feel free if anybody has any questions for me directly, or they want to get in touch with me. I've got I can get you my email, and certainly happy to connect with you.
I'm just checking for any messages. A lot of people, awesome. You great, Dan. Thank you. They want your email again. Maybe you can type that in. Go down the chat and type that in.
I just did. Oh,
perfect. Thank you. And then yeah, man, I'm excited. We'll definitely have you back on again. I mean,
I'm just excited that, what I would say is, there was a comment that, or a couple comments that really prompted me to be like, well, look, hey, how can this is Softwave University, right? So let's treat it like it's a university, and let me help educate my colleagues. And so I would say, if any of you out there, if you feel passionate about something, or if you see something that you want to try to help educate us on, like, reach out to Matt and be like, Matt, I got a great idea. I want to talk about this. And like, hey, let's all learn from each other and learn how to, sort of change the world with this device.
Rising tides raise all ships, right? And that's what it's about. And I'm so glad you're able to share some of that specialized knowledge with us and bring us up a game. And I think one of the best things you said is like, refer. I'll tell you a quick story. When I was early on in my chiropractic career and up in a farm country in central New York, and this one guy came in with terrible low back, and it was Mr. Emerson. I'll never forget. And I sent him, I took some x-rays, and he had aortic aneurysm popping out there. And I sent him to the vascular specialist, Dr. Porter. And that Dr. Porter said, your chiropractor saved your life. And didn't that farmer go and tell all his buddies? And didn't Dr. Porter, like, you know, so it's just, you never know how just doing the right thing one time will help build your practice. So, okay. I don't see any other questions. Everybody really liked what you had to say, Dan. Thank you so much. We'll do a follow-up in a couple
Thank you for
months.
having me. Yeah.
And thank you guys, and we'll see you in 2 weeks.